All right, so we'll go ahead and get started. Hello, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. The public slide deck will also be made available on our website under the Education tab, which I'll post a link to in the chat. Following the presentation, we invite you to raise your hand or type questions in the Q&A. And in particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, for upcoming LHS events, we are hosting 2 impact seminars in October. The second event is a special edition of our impact seminar featuring Linda Zittelman, co-director of the High Plains Research Network and senior instructor in the Department of Family Medicine at the University of Colorado School of Medicine. Linda is an expert in community engagement and has been working with rural practices and communities on a range of studies and managing multi-site, multi-method research projects. She will share experiences from the Colorado Practice-Based Research Network during her talk this Thursday, October 6th, starting at noon. As you know, registration is required for all of our events. For those that have already registered, we thank you, and you've already been automatically registered for the special edition. Our seminar series will return to its regular schedule on November 1st with Dr. David Dorr of Oregon Health and Science University presenting data-driven learning health systems using patient-facing digital health applications. And with that, I'll turn it over to Dr. Genevieve Melton-Mukes to introduce our speaker and the seminar series.
Hi, everyone. I'm thrilled to be able to introduce Tom Campion, who joins us today from Weill Cornell Medical Center as today's impact seminar speaker. Dr. Campion is an associate professor of research in population health sciences in the Division of Health Informatics. He also serves as their Chief Research Informatics Officer and Director of Biomedical Informatics in their CTSA. And there he also leads the Architecture for Research, Computing in Health, or ARC program, which matches scientists with tools and services for obtaining electronic patient data, which he'll talk to us a bit about today. Tom is highly active in the medical informatics community nationally and really a thought leader in research informatics. He previously also trained at Vanderbilt University, so brings many experiences from there. And really, in addition to the work he's going to talk about today, has been doing a lot of work in measurement of the biomedical research enterprise. How do we do computable phenotyping, work in clinical decision support, interoperability and health information exchange, and how do we think about organizational issues in informatics? So with that, please join me in a warm welcome for Dr. Campion. And the title of his talk today is Supporting Clinical and Translational Researchers with Electronic Patient Data. Looking forward to it.
Great. Well, thank you very much for the introduction. It's great to be here. Why don't we go ahead and get started? So the way that today's talk is set up is first I will describe the problem as we've conceptualized it, and then go into our methods, both organizationally, how we go about supporting the needs of scientists with storage and computing, and then kind of tactically through our efforts of the ARCH program. And as we go along, feel free to ask questions, call out. I mean, for this to be as much of a conversation as anything. So to get started, as you very likely know, getting electronic health record or EHR system data to support any type of analytics, but clinical and translational research in particular is hard. And it's hard for a number of reasons. One reason is that the systems that are used for providing clinical care are not designed for research. They are transactional systems. They are not analytical systems. They're really kind of based off of the traditional model of having a vanilla folder per patient with lots of individual sheets of paper inside that folder. One sheet describing a history and physical, another piece of paper, containing a blood glucose result that may come back from the laboratory. Understanding everything about a patient as you flip through those individual sheets of paper it is really kind of what defined, how EPIC and other systems are set up today. But if you want to get all of the blood glucose values for a population of patients across all of those manila folders or out of EPIC today, that starts getting a bit challenging. We're constantly taking individual transactions and repurposing them for analytical purposes. So when you take a look at informatics for clinical care, arguably EPIC has solved this problem as being the one system to rule them all for how do you get data in to the one approach for how do you get data into the system. I say arguably because there's a lot of work to be done. But when you look at care, where there's one system to rule them all, it's not the same for clinical research. There's no EPIC for clinical research. There's no one system to rule them all. Instead, we have a variety of different tools, and navigating those is quite challenging. So then when you take a look at those tools and the EHR itself, it's important to understand the strengths and limitations of all of those things. Investigators come to me all the time asking, can I do study X with data from the EHR? I give the same unsatisfying answer every time. Well, it depends. We have to evaluate, fit for purpose of EHR data for every study. Taking a look at, what elements are structured and are of interest that we could query and obtain. Say things like, ICD-10 codes or quantitative laboratory results. But oftentimes other elements are only available in unstructured sources like physician notes. But getting those elements out of those notes will require a fair bit of text analytics work, of natural language processing work, and that in and of itself presents a challenge. And finally, but most importantly, is the need to obtain proper regulatory approval. Protecting patient privacy is of paramount importance. And as we're talking about the most sensitive data about people and their lives, and it's incredibly important to make sure that we have, things like IRB protocol approvals, through our institutional review boards that line up with the requests that investigators make of our informatics teams to release data. This further gets complicated as we engage in multi-institutional efforts, sharing data across institutional boundaries, engaging legal teams and other colleagues. So, kind of taken together, we really see that this is a complex socio-technical problem, and optimal approaches are unknown. Looking across the swath of CTSA institutions, as well as other academic medical centers and non-academic sites, we've been unable to find, a perfect solution to supporting investigators with electronic patient data, especially from electronic health record systems. So what I am going to describe today is a bit about how research informatics as a discipline and research informatics as a team at Weill Cornell helps investigators address these issues. And there's really three things that we do. We help investigators get data out of EHR systems, collect novel measures that may not exist in EHR systems, and integrate data from disparate sources to enable science. So a little bit about how we're organized at Weill Cornell to support the needs of researchers. And all of this comes through our Information Technologies and Services Department, ITS, which is the traditional IT department. And a lot of the traditional IT functions are represented in this gray box here. That describes really our foundational activities of IT infrastructure, which I often characterize as everything from the network jack on up. So, alongside traditional IT functions of network, infrastructure, email, are three specific divisions, all focused on supporting the needs of scientists. across the spectrum of activities from the conduct to the administration of research. On the conduct side of things is our scientific computing division, which really focuses on kind of all things big data and high performance computing. To put things in a little bit of perspective, one whole genome sequence for one human is about 1 terabyte of data. And we have anywhere from 3 to 12 million patients at our institution, depending on how you count. And if we have an institutional goal of sequencing every patient who comes through the door, we're going to need a lot of terabytes of storage space and very sophisticated compute resources to handle that. So we have, again, this is today more on the basic and translational side of the spectrum of needs, but increasingly coming into clinical activities as well. Kind of switching to the other side of the spectrum, focused on the administration of research, is a team that focuses on all things IRB, grants and contracts, kind of compliance and planning, all the cross T's and dotted I's of research, what you can and cannot do, who's involved, and how are you going to pay for it. I should point out that while Cornell Medicine is the medical school of Cornell University, we are located in New York City, so about a 4-hour drive or so from the main campus in Ithaca, New York. And many of our administrative organizational units are separated, including the IRB here at the medical school. So that's kind of why we run things like the IRB system, the clinical trials management system, grants and contracts, all specific to the medical school here, and why we have a separate organizational unit focused on them. And then finally, in the middle is our research informatics group. We bring together the activities of either side of the spectrum shown here, as well as the activities of the clinical enterprise, which are not shown here, but I will illustrate going forward. And the confluence of these activities from these three organizational units plus other partners throughout the institution is something that we call Architecture for Research Computing and Health, or ARCH, which is really a suite of tools and services supporting the varied needs of scientists as they seek to conduct retrospective studies all the way to prospective studies. And another way of thinking about this is supporting the spectrum of activities from the study of populations through to the study of individuals. You can see here that there are some cross-cutting activities that pertain to all of the different studies across the spectrum, and then some things that are kind of more specific to one side or the other. We'll kind of walk through what these different activities mean, but the important part of ARCH here is to really help investigators understand the varied approaches that exist. And also early in my career, I learned that to succeed in academic medicine, you need lots of lousy acronyms. ARCH is one of many that we'll cover today. So we'll kind of walk through what each of these boxes represent and how they manifest in different systems as we proceed through today's conversation. But there's one thing that I remind our team all the time, and that's that science does not happen in the systems represented by these red boxes. Science happens in a statistical software package like SAS or Stata or R or Python. And what our job in informatics is to provide data sets that are immediately amenable to statistical analysis in these types of software packages, so that scientists can do research, so that they can perform epidemiological studies, create new predictive models, really do the work of discovery, the things that we're really known for in academic medicine. But the picture in academic medicine is not always so rosy, as illustrated in the citation from JAMA that I'm quite fond of. It really says that in academic medicine, we're great at breakthrough, we're great at discovery, publishing papers, getting grants, but we're lousy at follow through, that we don't take, the evidence that we create and optimally put it back into care. But the electronic health record system provides a platform for us to potentially address this issue, to take what we learn, to take our predictive models, to take our discoveries, and to make interventions in the electronic health record to help shape clinician and patient behavior at the point of care. These can manifest through things like best practice advisories or order sets, maybe changes in user interface, a variety of different interruptive and non-interruptive nudges in clinical workflow. And then by making these changes in the EHR, we can then get data back out so that we can measure whether we had an impact. Did we make things better, worse, or have no effect? This data-driven feedback loop illustrated here is what policymakers call the learning healthcare system, and this is what we seek to enable. I mentioned that the different functions really manifest in a variety of different tools and services, and that's really what this slide seeks to illustrate. The purpose of this slide is not for investigators to look at it and see, oh yeah, and I know exactly what to do now. The purpose of this slide is to illustrate the alphabet soup of acronyms, of logos, of systems, of approaches that are there. So much of the time, an investigator will come to our group saying, hey, I need an I2B2 project, or I need to run an I2B2 query. We'll sit down, we'll meet with them and see, no, what you really need is a REDCap project, and vice versa, and all sorts of other permutations there. We have found over time that this is a huge way that informatics can add value, because it is unclear how all of these different systems, all these different pieces of the puzzle fit together to members of the investigator community. They're focused on other things, on patient care, on scientific discovery and analysis in a particular domain. It's too hard for them to keep up with all of these different tools and services. Instead, what we do through the ARCH program is we match investigators with the right tools and services, as illustrated here, plus a few others, based on engaging with investigators to help understand their scientific goals and other factors. So what I aim to do here is kind of walk through a bit more of how we achieve this. And just a little bit about how we're organized within our research informatics division. We have 3 sections. Our data science services is really the set of investigator engagement for all of the applications shown inside of this blue box. This is really kind of how to interact with analytical data sets, how to thoughtfully interrogate the complex and nuanced clinical data that comes out of electronic health record systems. Our clinical and translational services section focuses on systems that support individual scientific workflows, whether these are things like informed consent, biobanking, collection of data through chart review, surveys, making interventions in Epic, really kind of these individual transactions. And then undergirding all of these efforts is the work of our software and our data and software engineering section, which does far more than is illustrated in that little cartoon at the top of running our data warehouse, which we call Super, or secondary use of patients' electronic records. Just a little bit of background. Our team has slowly built, or rapidly rather, built a data warehouse by obtaining data from the kind of the 2 halves of our clinical enterprise, our physician organization through Weill Cornell Medical College, and inpatient and emergency data from our hospital partner, New York Presbyterian. This figure is out of date, but it really starts to illustrate a variety of the electronic health record and ancillary clinical systems from which we've obtained data, along with a variety of research systems too over time. And all of this is kind of culminated in a push that we have to make data research ready. And that's a term that we see more and more in the literature these days. And we've kind of taken a look at the fact that it's not just, get all of the data out of Epic or get all the data out of this system or that system. So much of this, as you kind of go from the bottom and work your way to the top of this figure, involves a lot of detail-oriented investigation and transformation of data. We've estimated that it takes probably more than half of our staff's time just to get all of the data into a format that starts being amenable to analysis by investigators, and that there's a huge amount of training that we need to do, both formally and informally, through kind of workplace activities, and very likely also through master's and PhD programs, to help create the types of people that we really need to support the needs of scientists over time, using all of those different applications that we took a look at on the previous slide, that increasingly drive not only what we do locally, but also what we do for multi-institutional networks, some of which we'll describe as we go along here. So kind of, taking a step back and considering the suite of tools and services, kind of want to walk through each of these to illustrate what they mean. And kind of the bedrock of all of these things, the foundation, is really EHR reporting. And for a long time, we had two EHR systems at our institution, Epic on the outpatient side, Allscripts on the inpatient side. And through a great deal of work along with Columbia University, who also shares our hospital, we were able to put in place a unified intake process for this, something called the Tripartite Request Assessment Committee, or TRAC. I told you there would be bad acronyms. There are more, but that's really helped us engage the investigator community to create reports of data. Kind of these one-off reports. And what do I really mean about these one-off reports? Investigators oftentimes, they're seeking data from the EHR, and they'll often ask, well, the data's in the EHR. Can I just have the data from the EHR? What we're looking at here is a screenshot of data from the EHR. In fact, the Epic Clarity reporting database that some of you may be familiar with. And I was talking about rows and columns of data before. These are rows and columns of data, but these are not rows and columns that investigators probably want. Kind of taking a look here, we've got different columns: a patient number, an encounter number, something called a DX ID, which might mean diagnosis ID, and then multiple rows. These rows, it's probably one or more rows per encounter, so a patient number could repeat. And a patient could have one or more diagnosis codes assigned to each encounter. But kind of looking at this, and especially at this DXID column, these numbers don't mean anything. These are machine readable; they are not human readable. And it's only when you join in data from another source, in this case, we're looking at ICD-9 codes, that the data start to take on more of a human readable aspect. So just off the top of my head, I know that any ICD-9 code in the 250 dot range typically pertains to diabetes. So if you're looking to kind of take this data set and start creating a research-ready data set of, say, dichotomous variables, yes or no, this patient has diabetes, you could do that using a set of rules and transformations, because very likely an investigator doesn't want the rows and columns that we're looking at here on screen. Instead, what an investigator wants is what we're now looking at on screen, of not the machine readable, kind of machine encoded data, but the type of thing that they're really thinking, this is what I want to import into SAS or Stata. So here we're looking at, rather than one row per encounter, we're looking at one row per patient with a variety of demographic variables, and then dichotomous variables that we created through rules. And so we did all of this work of saying, all right, make a dichotomous variable a value of yes if a patient's ICD-9 codes are in a particular range. We could adjust that further. We could use things like laboratory results instead to drive that. But we could then repeat this process for other comorbidities, and then into other clinical areas like medications and social history. By no means am I saying that investigators only want dichotomous variables, but a lot of the times, these are the types of things that investigators are really thinking about to drive their analyses, and we really want to try to meet them there. Because this is the expertise that we bring in informatics, and because a lot of investigators don't want to spend all of their time doing this data cleaning effort, but this is an illustrative example of the challenge that we face in taking data and making it research ready. And this kind of forms, I think, the basis of a lot of the work that we're doing these days, especially to support the majority of investigators who maybe don't have formal training in informatics and data science. So that process that we just took a look at often involves a couple weeks of back and forth with the trained database analyst to say, all right, I want the blood glucose value that appears in the upper left-hand corner of EPIC, not the lower right-hand corner, because that then forms how one goes about extracting the data from the underlying database. But sometimes investigators don't yet need all of that detail. And instead, what they really need is a count of patients meeting certain criteria to help inform activities preparatory to research. For the past several years, at Weill Cornell, we've used I2B2 out of the group at Partners Healthcare in Boston. I2B2 stands for Informatics Integrating Biology in the Bedside, yet another bad acronym, but it's a super valuable tool. And with I2B2, basically you take all of your data from a clinical system like EPIC, and you transform it into a particular format to provide what you see here. A hierarchical view of data, arranged in folders, so that investigators can kind of point and click and run queries, so that in a matter of seconds, for example, they can see how many patients there are who ever had an ICD-9 code in that 250 range entered into their chart. And here we're saying that it took about 3 seconds, and there are 70,000 patients. Could refine this further by then, adding in say a hemoglobin A1C over 6.5 to further draw down that number, and really start focusing in on defining a computable phenotype for the particular condition. Tools over time have really advanced for exploring clinical data, but we continue to find I2B2 to be an excellent gateway to exploring clinical data for faculty, staff, and students. So a limitation of I2B2 in a particular academic medical center is that it's often limited to just the data from that academic medical center. So at our institution, it's just the data for Weill Cornell and New York Presbyterian. But if somebody falls down and they hit their head and they end up in the emergency room at NYU or Montefiore, we don't have that in our data. But through the Patient-Centered Outcomes Research Institute, PCORI, for the past number of years, as part of the PCORNet research network activity, Weill Cornell has been the coordinating center for the Insight Clinical Research Network, which brings together electronic health record data from all of the major academic medical centers in New York City, to be able to close those gaps, of healthcare fragmentation, so that we can answer those types of questions and address other important questions, especially in areas of rare disease. Renu Kaushal, who's the chair of the Department of Population Health Sciences, is the PI of this effort, and has enabled a great deal of research productivity locally and nationally over time. In addition to the Insight Network, we've also engaged for other multi-institutional activities, including with biopharmaceutical sponsors through a company called Translational. Translational had a brilliant observation many years ago that I2B2 is incredibly valuable for for academic medical centers because it presented counts of patients in a de-identified fashion to really encourage activities preparatory to research, for which with subsequent IRB protocol approval, investigators could then obtain identified data. That's exactly how we've implemented I2B2 at Cornell, and other academic medical centers have as well. But Translational saw that, who else would really stand to benefit from that data? Pharma. And this is what's so brilliant about it. Pharma gets to query data, but pharma doesn't actually get their hands on data. This is they just get counts of patients meeting criteria for particular studies, as documented in the EHR. Really using data that are otherwise just on the shelf. There's further configurations and participation levels of Translational that the company has rolled out over time that involve the sharing of row-level data. But for a lot of institutions, including Weill Cornell, this remains the primary mechanism for us engaging with this, because we don't actually share data with pharma. Instead, what we get that comes out of it are clinical trial opportunities. And these are emails that come in from Translational saying, based on a query, Pfizer or whichever pharma sponsor would like to do a study, a phase 2 study of drug XYZ. Are you interested? These figures are a little bit out of date, but you can see over the 4 or 5 years that we've been doing this, we've gotten more than 300 clinical trial opportunity requests that have come through the door because of Translational's participation. Each year we go to our clinical trials office and ask, do you want to keep doing this? Is this of value? And they say, yes, we are getting trials that otherwise we would not have gotten. So we continue doing this. There's a great deal more of measurement and impact that we seek to understand as well. So Translational is really intended to help grow sponsor-initiated trials. And through the NIH and the Clinical and Translational Science Award, or CTSA consortium, many institutions also participate in the Accrual to Clinical Trials, or ACT network, which really aims to do the same sort of thing, but using our existing I2B2 infrastructure to foster investigator-initiated trials. I believe this is about to evolve further into something called ENACT. It just continues to evolve. But again, this connects at the time, the last time I looked at this, about 48 of the 60 or so CTSA hubs had agreed to participate, and we'll see how this goes going further to help grow investigator-initiated trials. Another set of activities that we've launched over time really falls under the category of big data analytics. This is what kind of started getting us to start expanding our arch figure a bit more over time, and going with the activities of the observational health, data science and informatics, or Odyssey community. We've really embraced this philosophy, this set of tools to help support those investigators who are coming to us saying, hey, I would like, quote unquote, all of the EHR data because I have sufficient data science skills and I want, high dimensional data. And we're kind of looking at it saying, well, we've got all the data from the Epic Clarity database. This is, anywhere north of 14,000 proprietary database tables. And these are really complex. There are dragons lurking behind every corner. Do you really want these? Because, it's a full-time job just to kind of understand these things. I've heard this saying of, if you've seen one Epic implementation, you've seen one epic implementation of just because, you know, two academic medical centers have the same EHR system. That same EHR system is often implemented in different ways. Data are stored in different places, and it's really difficult to kind of translate from one institution to another how to query it. So, you know, there's this headline here from the New York Times from a few years back that I think was quite apropos of, you know, that big data science requires this quote unquote janitor work to really make data available. And that's kind of undergirded our approach with how to support these big data scientists, of using something through Odyssey called OMOP, the Observational Medical Outcomes Partnership Clinical or Common Data Model, that really specifies there's about 20 tables that all are standardized. They're not proprietary. It basically says, if you map your data according to these rules into OMOP, and if I, at my institution, follow the same conventions, we can have standardized data that use things like reference terminologies like ICD-10, SNOMED, LOINC, and others, so that we can be able to compute the same sorts of analytics. This is just a depiction of the OMOP Common Data Model. You know, as you can see on the left-hand side of the screen, you know, things of kind of, you know, general understandable purpose of, you know, we have a table describing persons, we have one describing drug exposure, condition occurrence, measurement is really where a lot of the laboratory results go. And then on the right-hand side, kind of the standardized vocabularies of all of those things, all of those elements in the tables on the left being mapped to the elements on the right, which really capitalizes on decades of medical informatics research, and a huge push by the federal government through things like meaningful use to make sure that reference terminologies are part and parcel of everyday EHR system transactions today. So OMOP has been a big part of how we've started to roll out local investigator support for data science. And it also undergirds a lot of the multi-institutional data sharing initiatives we have these days, including the All of Us research program, funded through the NIH, which aims to enroll 1 million people living in the United States to consent to provide their specimens for sequencing, their electronic health record data, and a variety of other data, including survey responses, Fitbit, and other elements, to help create a resource that I kind of liken to a 21st century Framingham heart study. It's kind of, you know, Framingham meets 23andMe a bit. And having all of these data available at different levels of access, depending on regulatory approvals, to investigators. And these are just some screenshots of the All of Us researcher workbench, as it's called, which brings together all of these different data elements, all based on the OMOP standard, so that investigators can interact with it, as you can see here, you know, using a Jupyter notebook, you know, one of the common tools of data science today. This is just, I think, an excellent example of how all of these investments and how so much informatics research is really starting to converge and pay off to enable science at a large scale. More recently, the National COVID Cohort Collaborative, or N3C, also selected OMOP as its standard. This slide is out of date, but I think it's something much closer to 100 sites today that are contributing data. All the data ends up getting mapped into OMOP, and then investigators, similarly, as you can see here, can interact with the data through an online portal based on particular sets of regulatory approval. And as you can see here, write SQL queries against the OMOP Common Data Model to help better understand COVID and long COVID. Again, just a standing example of how all of these activities are coming together and how they can help reduce time to science. So kind of switching gears to the right-hand side of the spectrum, you know, really focused on perhaps prospective studies or the studies of individuals. and obtaining data elements that may not already exist or require kind of further augmentation, further annotation. And a great tool for this is REDCap that comes out of Vanderbilt University and stands for Research Electronic Data Capture. We've kind of expanded this over time with further automation through something that we call Super REDCap, using some plugins that Vanderbilt's made available, as well as a Fire-based version. I'll kind of show what those mean here. So REDCap, for those who don't know, is kind of a survey monkey for research, is how I often describe it. It's a build your own case report form and survey tool. And what we're looking at here is a case report form, with kind of standard elements you might expect to see in a chart review study. Things like medical record number, name, date of birth, maybe which cohort people are in. And the folks at Vanderbilt observed that so often study teams had REDCap open on one screen and the EHR system open on another. And study teams were just copying and pasting elements back and forth and thought there's got to be a better way. So what Vanderbilt developed was a plugin that basically said, if you provide a medical record number in a particular field, REDCap will take that medical record number and go and retrieve it from an external source like your electronic health record system or your research data warehouse and show it to you so that you don't have to copy and paste it. So we're looking here at some demographic elements for a test patient, and a research coordinator would look at this and say, yep, that's the right person, press save, and then those elements are automatically stored into the case report form. We've observed at Weill Cornell, just as Vanderbilt has, that this helps save investigators time, and it also helps reduce data entry error. And this has really gone a long way over time to not just supporting things like demographics, but also say temporal variables or temporal elements, things like laboratory results where there might be a lot of them. So that when combined with a visit date and an MRN, it will this Super REDCap will go and retrieve all of the elements of interest. In this case, we're looking at an example of platelets, so that investigator could select this one, not that one, further facilitating the chart review task. And really kind of expediting the entirety of the data collection process. Further helping to bring together clinical and research workflows, there's now something called REDCap on Fire, which enables the launch of REDCap with all of the integration of being able to bring data elements into REDCap case report forms, and doing this all from inside of Epic. Using the FHIR standard, the Fast Healthcare Interoperability Resource Standard. And this has really helped further bring together clinical and research workflows at our institution and elsewhere. So kind of taking a step back, a number of years ago, we saw that there was getting good uptake of these tools, but that investigators would end up having a REDCap project that would generate a spreadsheet of data elements that they needed, but they also, for say the same patient cohort, had another spreadsheet that they got from the Epic team describing outpatient activities, and then another spreadsheet for that cohort describing their inpatient and emergency activities they got from the team that managed the Allscripts system, and another one describing their perioperative behavior, another of a spreadsheet that they have just describing their homegrown biobank system. And all of a sudden investigators were swimming in spreadsheets, and this data wrangling challenge was too much to bear. So the solution that we devised was something called custom research data repositories, or RDRs, where we recognized that what we could do, and we're kind of using emergency medicine as an example here, is we could bring together all of the data of interest for a particular group of investigators and regularly refresh that and have that available in an identified fashion so we could support a variety of studies going forward. And then by having all of the data that are raw, they're not yet research ready, they're not yet transformed, we could then make them available through multiple tools to support 3 different workflows. Discovery and collection, as illustrated by I2B2 and Super REDCap. And the biggest one is really that transformation of data elements, this analysis function that we accomplish through plain old Microsoft SQL Server. And early on, we saw a need to help investigators understand that we can't create, one data set, one database to support every single study going forward. Instead, let's really try to focus on the needs of 2 different studies with 2 different sets of rows and columns and go from there. For example, with our digestive care team, the first study focused on colorectal cancer, the second study focused on cirrhosis, different cohorts, different rows and columns, different variables of interest, different groups of investigators, but really helping to channel the thinking so that we could help grow a lot of scientific output from those 2 sets of resources. I will point out that nearly all of the resources that we've shown today, we make available free of charge to investigators at our institution, but these custom research data repositories, we charge $50,000 to start and then $7,500 on an annual basis as a maintenance fee. These fees come nowhere close to recovering our costs. They just really help ensure that investigators are engaged, that they have skin in the game. The number of times where I've sat in a meeting and an investigator says, and I want to understand, how many of my patients have cancer and diabetes? And then I ask, well, how do you want to define cancer? How do you want to define diabetes? Do you want to use ICD-10 codes? Do you want to use particular laboratory values? And investigators kind of, pushing back from the conference room table, kind of sighing and realizing, this is going to be some work. But that engagement is important. We've been able to replicate this about 20 different times or so with all of these different groups here. And so many different groups, especially as we're in these large academic medical centers with such broad clinical coverage. The definitions of clinical concepts vary. The goals of different groups vary, but having this engagement is critical, especially because we don't yet have widespread understanding of biomedical informatics and data science principles to drive all of this. We've since been able to describe these efforts in a data catalog to encourage collaboration across groups, to let everyone know of the different resources that exist to help bring together investigator groups so that they can more readily use these data resources. And then, all of this really came to a head in March of 2020. Here we were in New York City, then the epicenter of COVID in the United States. And we were all of a sudden, pressed into doing clinical informatics duty with our clinical research informatics infrastructure. Turns out the resources that we built over time were quite valuable to support patient care. But what we also needed to do was respond to an unprecedented number of requests. And we really use the same types of approaches that we've developed over time, just with a twist. So we developed something that we call the COVID Institutional Data Repository. Again, bringing together all the data from disparate source systems. And then kind of a priori, we made a series of transformations, not based on OMUP, but even simpler than that, because we knew that we were going to have a variety of different use cases to support, but we still wanted our same sets of engagement and compliance processes to be in place. But we also understood there would be a lot more investigator self-service, and this infrastructure really took off and supported a great deal of research and clinical care that a separate website helped to drive. And we have a paper describing this initiative and some of the comparisons of automated versus manual data capture that it enabled, and I can share that citation. But kind of taking a step back, looking at this suite of tools and services that we've conceptualized, the way that we've been able to support a variety of different clinical, basic and translational science, as well as pandemic activities. There may be elements that are of use to other institutions, and I'll also be sure to include a citation to our JAMIA paper, which came out describing ARCH earlier this year. But to just kind of draw things to a close, there's really three things that research informatics helps investigators do, and that's get electronic health record data, collect novel measures, and integrate data from disparate sources. A lot of this work is janitor work of cleaning up these data, and that's really making the data research ready, transforming it from its raw clinical grade. And the way that we do this through ARCH is by matching investigators with the right tools and services, by taking into account things like study design, the sources of data that are necessary, and costs. It takes a village to deliver these types of activities. I'm unbelievably thankful for our leadership, funding from our CTSC and institutional sources, as well as our team in research informatics and our project management office. A couple of resources shown here, and I'm happy to take questions and field comments. Thank you.
Thank you, Dr. Campion. So we have about 8 minutes remaining or so for Q&A. If you have questions or comments, you can raise your hand and ask the questions verbally, or if you'd like, you can put them in the chat, or if the Q&A is working, you can do that as well. We did have one question from Sam come in during your presentation. Was it difficult to get permission to do this kind of data pull from EMRs directly into REDCap?
Great question. Yes, the technical work, it was some work there, but it was, really approaching our clinical IT colleagues and building that trust over time to do this sort of thing. That took a few years, which was really predated from us getting our data warehouse set of activities off the ground. So when it came time to do this with REDCap, it was a little bit easier, but I cannot emphasize the importance of building trust with clinical IT colleagues.
All right, I see that Genevieve has raised her hand.
Hi, Tom. I was really curious about the $50,000 and kind of what's that model? How does it work? How far does that set of services go? Yeah, really curious about that.
Great question. We have a manuscript that we wrote describing this, and then the pandemic hit and we never finished it. We really got to get this out the door. We've seen that the $50,000 serves as kind of a rate limiting step for a lot of groups. That instead of groups saying we want to create a database, which is I think often the language that clinical research teams without informatics or data science skills use, we've really tried to use the $50,000 to channel thinking, to say, all right, but what do you really want these rows and columns to be? What grants are these data sets going to enable you to pursue? What quality improvement initiatives locally can they potentially enable as well? The costs, as I mentioned, come nowhere near to recovering the true costs that it takes for us to deliver our service. But this has at least kind of helped to guide thinking, to make some things far more mature. As we look at this kind of unsolved problem nationally of how do we get more faculty who are not informaticians to thoughtfully interrogate data, that this is one potential way of doing it. I should mention too that over time we've had to really emphasize to our investigator community that clinical data from the EHR system and other sources are available free of charge to members of the research community. But thoughtful interrogation of the data that carries a cost. One approach is to partner with our team through one of these research data repositories or some kind of other sort of cost recovery activity. Another approach is to partner with a biostatistician who may have the technical abilities to query the data, likely with some oversight from informatics. And a third option is for an investigator to do it themselves. But again, that has a cost too of time. But we want to really provide multiple avenues for investigators to interact with data, recognizing that investigators have a diverse set of skills. Does that answer your question?
It does. It does. Thank you.
Okay, we have a couple of questions in the Q&A. So I'll start with Eric Bean first, as I think it's a shorter question. Did you say that you were using Firebase as a resource? Are there any privacy and HIPAA concerns around using Google/Firebase?
To the best of my knowledge, we are not using Firebase, and I'd have to go back in and look at the actual technical details of the Fire implementation that we have with Epic, and the way that the REDCap team has implemented some of those things. So we are very conservative in the way that we approach these things. Our clinical IT colleagues are pretty conservative too. Everything that we end up putting in place, we always make sure has the full vetting and approval of our privacy office.
Okay. Question from Rubina Rizvi. Regarding HIPAA and data collected as part of standard medical care, we got an email from compliance personnel that using the Academic Health Center data shelter to gather participant information from the EHR through the use of the opt-in status is only approved for retrospective chart review studies that do not include an intervention. Is that true for a non-medical intervention like a tool facilitating workflow? And do you have any insight there? So I think this is a comparison between University of Minnesota regulatory and your experience.
Gotcha. There's a lot to unpack here. So what I think this is about is, to perform a retrospective chart review study. Hold on. These are the opt-in status. My understanding is that very likely here at Weill Cornell, we would still want there to be IRB protocol approval or some kind of IRB decision about the study. And then we would make the tooling available, including Super REDCap and REDCap on Fire. But we always look at the regulatory approval to make sure that what we're putting in place through Informatics is consistent with the regulatory approvals in place.
Okay. And our last question, how many full-time staff do you have to build and support these research informatics resources? And how long has this work taken to build to where you are today? Great question. So we're at about 25 or 30 people today in our team. And that does not include, the efforts of our infrastructure folks that, run our databases, our security folks that keep bad actors out. But that's really focused on, the people who, deliver that that stack of resources to make data, to transform data from its raw form into a research ready form. It's taken us close to a decade to do this. I think I've been in this role, I've been at Cornell 13 years, and this role about 10. And it's really taken time to build this capacity. If I had known then what I know now, I think we'd be able to move a little bit more quickly. And that's part of what we're trying to promote through the CTSA consortium, so that groups can reduce the time to science at their institutions. All right. Thank you, Dr. Campion, for taking the time to present today. And thank you all for attending. In closing, and as a reminder, we have 2 October Impact seminars. The next one is this Thursday at noon, a special edition with Linda Zittelman. This concludes our presentation. See you next time. Terrific. Thank you, everyone.
Thank you, Tom.
Take care. See you.